We are dealing today with head, neck, and spine trauma. And so this is going to be a three-part series on Chapter 6. And again, just as a reminder, I'm going to try not to hit every slide, but we're going to hit the big points that we need to hit in head, neck, and spinal trauma. And there's a lot of things that we got to cover in this part in dealing with what it is that we're going to be seeing with our trauma and our trauma patients, because the head spinal trauma is a little bit different than a standard trauma patient and the way that they present. Remember that the brain is an enclosed capsule. It's an enclosed space. There's no room for if the blood is leaking out of the tissues or arteries or veins, that there's no other place for it to go. It builds up pressure inside there. As it builds up pressure, unfortunately, it starts squeezing everything out. I call it the Play-Doh Fun Factory, because that's kind of what it's like. You get too much pressure up here, and it just presses down, pushes that brainstem through the foramen magnum, and then again, all kinds of problems happen. Especially lethal, by the way, in auto crashes, and especially maybe 20-30 years ago when people weren't wearing seatbelts as prevalently, and they were going straight forward into the dashboard and into the windshield and into the things that are front. And then if they do survive it, by the way, they're going to have some sort of disability to where they really can't, whether it be brain damage, traumatic brain injury, or paralysis of some sort. And again, the most prevalent, by the way, males between 15 and 24. Yep. Hold my beer, watch this, okay? And unfortunately, that's very true. Infants and young children and also the elderly are involved in this category. So again, the good news is we've done a lot more with wearing helmets, with wearing seat belts, with protective equipment. So the good news is we have seen a decrease in these type of injuries, but they do still happen, okay? And again, when they have spinal injuries, one of the biggest problems is we really can't tell whether or not there's spine damage going on. They become a little bit more lax about spinal clearance and the way we treat our spinal patients, and I'll kind of go through this as we're going through the slides here. Again, one of the things about the head, of course, is covered by the scalp. Very vascular. Scalp wounds bleed is the best way to say it. The hair, by the way, it's an insulator, and it loosely attaches to the skull. Scalp is actually an acronym: skin, connective tissue, aponeurotica, the white stuff, a layer of subaponeurotica, and then the skull's periosteum. Okay, so those are the 5 layers of the scalp. The cranium itself it's got the skull. Again, that's your bony part. The vault that holds the brain is known as the cranial vault. And then again, your facial bones, and there's so many of those and so many little ones. Okay, we kind of went over this in A&P, but as another fresh reminder, I would probably know the big ones in the scalp. As far as these up front, I think that they're good to know. Again, mandible, maxilla. The ethmoids, the lacrimal bones. The way I remember lacrimal bones is it's in the back of the eye, and therefore that's where you cry from. Lacrimation is crying. The nasal bone is up front. Your sphenoid is between the temporal and the front areas, and these guys are kind of, again, the fracture usually occurs somewhere along a suture line. And then hopefully you know all these: the occipital, the parietal, the frontal. Again, the zygomatic processes of the temporal bone is where there's a lot of muscle attachments. It's where the ear is, basically. Same way with the temporal. Now, the cranial vault, again, they're the bony plates, and remember, there's little bones up underneath. If you looked at the bottom of the head in one of the labs, you can see where there's the little bones that are kind of protruding up. It's ligament attachments for different parts of the brain, actually. So again, you can have intracranial pressure, and that's what we kind of worry about, is our intracranial pressures in more than it should be. And the problem is there's very little compensatory mechanism for that. Now, the one thing that is the meninges, and that's the 3 that are covering. It usually got, by the way, cerebral spinal fluid bathes the brain, and so you can push out a little bit of cerebral spinal fluid for minor swelling stuff. But again, if you're dealing with massive pressure, and that's why they usually end up drilling burr holes to relieve the pressure so that you don't have stuff squirting through the foramen magnum. You relieve the pressure by removing a plate or removing. I'll give you a perfect example of that is Roy Horn, the magician. When the tiger bit him, he actually gave him a depressed skull fracture. They actually took the piece out, allowed the brain to swell, but they put then they took the bone and put it in his abdomen to keep the bone alive. And then when the brain swelling went down, they reattached the skull plate. Now the meninges, the dura meat of the pia mater, and the arachnoid membranes, I would make darn sure that I know these, and I remember it by DAP, D-A-P. Outside is the dura mater, inside's the pia mater, and the arachnoids in between. Okay, that's the way I remember it. So again, one of the biggest problems with your head trauma is that you'll get bleeding inside, in between these layers, and again, that can cause major problem. Again, we just talked about the cerebral spinal fluid, how it bathes the brain, and again, by the way, very sterile stuff. We don't want to get this stuff on us, if at all possible. But again, if you have, when you're dealing, by the way, with any type of ventric or any type of something going into the brain to get cerebral spinal fluid, strict sterility, okay? You really do, because boy, you can get an infection in there really quick. The brain, again, it's about 80% of the volume of the cranial vault. Again, the cerebrum, the cerebellum, the brainstem, the different parts of it. We talked about this during A&P. The falx cerebri is what divides the cerebrum into the right and left hemispheres. Remember that, by the way, a little bit of useless trivia. Albert Einstein's, it was so complex it looks like he didn't even have a separation between his left and right brain. Then you got the central sulcus is the fissure that splits the cerebrum into the left and right hemispheres. Let's see here. Nice little, don't need to know that one. The Tenorium Cerebellar is, again, it separates the cerebrum from the cerebellum. Your Oculomotor Nerve, again, it's the one that controls pupil size. Okay, so the oculomotor nerve, again, it's inside the brain, of course. Now the brain, the right side dominant is usually nonverbal imagery, and left brain is kind of more your reasoning, your logic thinking. Just to keep that in mind. The right side is the more creative side. The left side is more the analytical part. Brain stems, again, the central processing system in midbrain is the pons medulla oblongata. We all remember that because that's what kind of controls our breathing. It contains the hypothalamus, the thalamus, and associated structures. That's what's in the midbrain. Let's see here. We already talked about all these guys here. The brain has a very high metabolic rate. It's a oxygen hog, it is a glucose hog, and when you start losing either one of those two, you're going to start seeing altered mental status. It's a simple fact of life, okay? When it doesn't have the fuel that it needs, okay? So they constantly need the glucose, thiamine, and oxygen. If they don't have that, you will die within 4 to 6 minutes if you don't have that. Again, the cool thing about the brain is it's got the circle of Willis, which is at the bottom of the brain. Basically, your two carotids go up into this circle of Willis, and that's from there it kind of distributes the blood to the brain. So even if you've got one that's blocked up, you can still feed the entire brain with just the one side. Venous drainage is usually into the internal jugular veins and then goes into the superior vena cava, and then again usually dumps right back to the heart. Blood-brain barrier. It's a it's a more complete, not permeable. It usually doesn't let water-based drugs through it. So that's why we, again, love propofol, because propofol just goes right through the blood-brain barrier and starts affecting the cells. Now, the cerebral perfusion pressure. It is critical for brain function. It's your mean arterial pressure minus the intracranial pressure. I will tell you guys, intracranial pressure is usually around 25 millimeters of mercury. Remember when I said you got to have a MAP of 60 to really function correctly? That's about the truth, because if you get below 25, your MAP is below 25, you're probably not overcoming your intracranial pressure. And why that's important is because if the intracranial pressure is increased, then you've got to increase your central perfusion pressure, and so you've got to do that, and therefore that's why your mean arterial pressure increases. Your blood pressure goes up. Okay, so Good news is, by the way, that your body does a really good job of trying to auto-regulate that. Matter of fact, I would say that it does probably a really big job of that. Now, your Monroe-Kelly doctrine. Yeah, this one they love to throw on the test, so make sure we pay attention. I can guarantee it's on mine. The intracranial volume, it is a fixed thing, is your brain volume plus your cerebral spinal fluid plus the blood volume, okay? So that's how we figure out how much volume is actually in the cranial vault. The key thing to remember is that the brain volume is usually fixed, okay? Mass or lesions or if it starts to swell, you can see where that's going to increase everything, so you've got to take out cerebral spinal fluid or blood volume in order to make that happen. And again, remember that the brain is a nutrient hog. It wants its blood supply. It's going to get that. Again, traumatic brain injury is when the intracranial pressure increases significantly, and therefore it impedes normal blood flow and then limits the CNS tissue perfusion. And when that happens, again, you really have the brain doesn't like that, okay? And so it's going to try to increase its own blood pressure in order to get blood up there. Well, what's happening is you've got that fixed cranial vault. There's not room for there to go. And again, there's only so much cerebral spinal fluid that you can get out in order to try to equalize the pressure. So, the long and the short of that is the brain, it's pretty much in a fixed spot. We can't, again, and if it starts to expand, there's really nothing that we can do other than to, again, and you're going to see that the blood pressure is going to go up. Well, when the blood pressure goes up, by the way, the heart rate is going to come down because everything is getting squished in the brain, and so it's saying, hey, we got to relieve the pressure, let's slow the heart rate down, but it's doing that strong bounding squeeze because it thinks it needs to get more blood up there. So again, it's all a compensating mechanism. Now, your cranial nerves, you got 12 of them. Yes, you are going to need to learn your cranial nerves, okay? There's the dirty version of it. I'll teach you guys that in class. But again, if you remember these, and if we remember we drew the face, the cranial nerve face back in A and P, that's when this is going to come into play. So that's the part that it controls. Now, the ascending reticular system, that's what, again, the nerves in the brain's midbrain, the pons, the brainstem, and that's what controls our sleep-wake cycle. It controls the respiration, heart rate, peripheral vascular resistance. It's all controlled from there, okay? That's the nervous control of it. The facial bones, again, it's the anterior structures, the skin, again, the subcutaneous tissue, there's small muscles in there, and again, your carotid arteries are also controlled in this general area. We've already taken a good look at the facial bones. We looked at the different cavities here. I'm good with that. The ear, remember that you got a middle ear and an inner ear as well, and the semicircular canals is there. And remember, I would probably know the names of these three little bones in here because that's what's going to do our hearing. This is usually, by the way, a blast injury usually pops these guys right here. Okay. So again, by the way, they usually the semicircular canals, by the way, and these, it's going to make it very difficult for these areas as well, because remember all of these are hollow for a blast. Again, your eye, you got your vitreous humor, your retina, your lens. We talked about all these in our special senses unit. Again, remember the light comes in, it hits this, and then it's traveled via the optic nerve into the brain and translated into signals. Again, your sclera is the whites of the eyes, so don't shoot till you see the sclera, okay? It just doesn't have the same ring to it. Cornea is a thin, delicate layer. It covers the pupil and the iris, and then the conjunctiva is a delicate, smooth layer that slides itself over in the cornea itself. We've already talked about these guys. By the way, 3, 4, and 6 are the nerves that control the eye. 3s are more to the upper top. The 4s are to the inside. The 6s to the outside. By the way, diabetics and shingles, very prone to get your cranial 6 nerve paralyzed, and boy, does that screw things up. You get to see double for about 6 months. Anatomic components of the neck, again, remember we got lots of structure in there with not a lot of protection. Okay, it's a lot of muscular protection, but not a lot of bone protection. The only thing that's really got bone protection is the spinal column. Okay, and as a matter of fact, that's kind of what the problem is, because you basically got a bowling ball on top of a stick, and it's very easy to break said stick. So again, it's one of the bigger problems that you've got when we're dealing with the head, neck, and facial and spinal trauma. There we go. Your carotid arteries, by the way, your jugular veins. By the way, any cut to the neck where we've cut a vein open, we really need to get an occlusive dressing on that, a hand, anything that we can get on there to stop an air embolism from coming in there. Again, we got your larynx, your epiglottis is through that area. Again, we are all very familiar with all of these structures. But also remember your esophagus, your cranial nerves also go through this area. You've got other structure in there, okay? Again, we talked about all those. So zone 1, by the, I don't think you guys need to know this per se. There's no real need for it. But your vertebral column, the thing about 33 bones in there, 7, 12, 5, 5, 4, you need to know. Okay, and then the vertebrae are what form the bones of the vertebral column. And by adulthood, by the way, the 9th lower vertebrae have fused, forming the sacrum and coccyx. Okay, again, that's the lower pelvis area. Again, all good with those. Spinal nerves, we're good with those as well. I would probably know about the spinous processes, the transverse processes, and then, of course, the vertebral foramen. That one's going to be in there. The body is the bony structure. In between these bony structures, by the way, are intervertebral disc. And we've got to remember, guys, that there's nerve roots that are shooting out of all of these spaces as well. So when you get a pinch area or squashed area in there, you're going to have nervous dysfunction. All right, we talked about all those. Atlas and axis, I would probably remember those. C1, C2. The odontoid process is it projects upward, and that's what the atlas rotates on, is that axis, which is the odontoid process. When you get an odontoid process fracture, that's the one, by the way, that'll be sitting there going, I can't move my neck. And they'll be literally holding their head like this, and the reason is because, again, essentially they turn left or right the wrong way. They're probably going to be dead. Okay. Again, your vertebral column, the thoracic. Sorry, guys, didn't mean to click on that. There we go. Talked about all those. There's a little bit of difference, by the way, in the way that the vertebral bodies are built once for the different ones. Just know that there are some differences there, and that's what I want you to know. Now, the spinal cord usually goes down that vertebral foramen, and again, it's what conducts the impulses to the brain, and they're usually fast tracks, and they go down to the spinal cord goes down to about L1, L2. That's where the cauda equina starts, where it basically splits off into that horsehair-like projection if you were to look at the nerves themselves and actually look at them. Remember that you've got gray matter, and again, these are usually neural cell bodies, and the white matter as well is usually the pathways, okay? Again, usually you have ascending tracks and descending. Ascending transmits up to the brain, descending down the cord. And again, these are usually, they usually go together, by the way, but there are different pathways that they go through. I don't want you to know those. Remember that your spinal meninges do go through, just like the cerebral ones. Again, dura mater, arachnoid membrane, pia mater, okay? And then you do have cerebral spinal fluid, which bathes that fluid. So this is, again, the overall look. Let me go back there. There we go. Yeah, that's your overall look here, gang, of where the different parts are. So your spinal nerves, you've got 31 pairs of spinal nerves. I don't want you to know that, but what I do want you to know is where the dermatomes lie. So if you're feeling basically levels of where each spot goes, that's where I want you to kind of know is your dermatomes, okay? Where do they feel sensation? It usually can tell us where the break is, usually with that. Now, blunt injury, that's the one, it's usually the most serious, and again, it usually involves the head, because remember, and it usually is very prevalent in young people, because their neck musculature has not developed yet into that region. Okay, so we're going to hold off right there, because that's going to be the end of the first part. I know I'll go yapping on, but a quick review of the anatomy and physiology. Break out your A&P book and take a good look, because it's probably going to help you. All right, guys, I'll see you on the next one.